I don't know if you guys are having the same out-of-body experience I'm having, but Dr. Hacker, please let me quickly introduce you before my Wi-Fi does something else strange. But Dr. Hacker is the director of CDC's National Center for Chronic Disease Prevention and Health Promotion, and leads an executive team that sets the strategic direction for the center's portfolio of more than 1,000 staff members dedicated to preventing chronic disease, promoting health across the lifespan. She is an expert in community-based participatory research. She has designed, led, and published on numerous CVPR health projects. She is also published in 67 peer-reviewed articles on a wide range of topics, including adolescent health, school-based health center, obesity, substance abuse, clearly chronic disease expertise, and health policy to top it off. Dr. Hacker, without further ado.
Thank you so much, Renee. I'm so glad you got through that without the internet breaking. So anyway, you heard, I'm Dr. Karen Hacker. I'm the director of the National Center for Chronic Disease Prevention and Health Promotion here at the CDC. And today, first of all, I'm very pleased to be here. I was very fortunate to hear the opening speaker. I thought he did a phenomenal job. And I think this session hopefully will take us off from there. As you heard, our center is pretty large. One of the things that we are really interested in is preventing chronic disease, but also addressing the very deep health inequities that we have seen and driving towards health equality. So one of the things I'm going to do today is talk a little bit about chronic diseases. First of all, in general, many of you know that, obviously, that even before the pandemic, yes, there was a before the pandemic, that we knew that 6 in 10 adults had a chronic disease, and about 4 in 10 adults actually had 2 or more chronic diseases. We also know that chronic diseases accounted for the 7 of the 10 leading causes of death in the United States. And although COVID has now pushed some of those out of the way, they're still the #1 cause of death. And so based on these statistics, it's clear that I'm sure you yourself may be an individual with chronic disease, or you likely know someone in a first degree with a chronic disease. It touches Americans in many ways. We also know that there has been a disproportionate burden of both chronic disease and COVID-19 severe illness in particular populations during this entire pandemic. A recent study of 12 states reported that 73% of people who were hospitalized for COVID-19 had at least one underlying chronic condition, and that the rates of hospitalization increased as the number of conditions increased. We know that the chronic diseases are the risk factors, such as things like obesity, and smoking are also risk factors for severe COVID-19. But we also know that these things have affected people of lower socioeconomic status and racial and ethnic minority groups. African American and Hispanics or Latino people, American Indians and Alaska Native people are all among the highest risk, much more so than non-Hispanic white people, of being exposed, getting sick, and being hospitalized or actually dying of COVID-19. These racial and ethnic minority groups are disproportionately impacted, as I noted, by chronic disease, and that puts them at greater risk of increased chances of getting severe COVID-19 illness and then being hospitalized, as I said, and mortality. And part of the challenge is also that these associated rates of COVID-19 are likely in part due to many of the conditions that these individuals may be living in. They may have essential jobs, which prohibits them from staying home during mitigation orders or being able to telecommute. They have to go into work. They may have housing conditions, which means that it's almost impossible to really socially distance. If a member of the family gets COVID-19, what are they going to do? Our data on race and ethnicity for people who died of COVID-19 has revealed that the percent of Hispanic or Latino, non-Hispanic Black, and non-Hispanic American Indian or Alaska Native persons who have died of COVID is higher than the percent of these racial and ethnic minority groups among the total US population. Now, these health inequities that we see with COVID were here long before COVID. And again, you heard about that this morning as the speaker discussed, the rates of diabetes and the rates of heart disease among particularly African Americans in that case. And these health inequities are due in part to the chronic disease challenges that we face, but they're also, as I noted, due to a whole variety of social determinants of health that range from housing conditions to socioeconomic status, to their occupations, to their healthcare access, their treatment within the healthcare system, their income, and their education. I could just mention so many more. We at NCC DPHP are looking at these disparities very carefully and really determining how we can focus on the social determinants of health. And in particular, we're focusing on, to start with, 5. These are social determinants that we feel are quite related to chronic disease, and they include things like food insecurity, social connectedness, community clinical linkages, the tobacco-free policies in a community, and the built environment. And the interventions that target these social determinants of health have a potential impact, have tremendous potential impact to help narrow these disparities among many chronic diseases by creating an environment that's healthier and that the opportunities are there to live one's healthiest life. Now, during the COVID-19 pandemic, the scope of chronic disease challenge that was already large has become even larger. The COVID-19 pandemic has further emphasized the importance of chronic disease prevention and care, especially because many of these chronic conditions, as I noted, increase the severity of COVID-19 outcomes. We know that cancer, heart conditions, diabetes, chronic kidney disease, in addition to being among the top 10 causes of death in the United States, are also established risk factors for severe illness from COVID-19. And additional chronic conditions or risk factors, including obesity and smoking, as I mentioned, but also being pregnant, can increase the severity of COVID-19 outcomes. Today, you're going to hear from a keynote speaker and a group of experts who are going to dig into the issues of COVID-19 and chronic disease. I'm going to start with an overview, and then we will have Dr. Magdala Sherry, Dr. Lisa Richardson, and Dr. Susan Cassandra share their insights. Our keynote speaker today is Dr. Magdala Sherry. She's a primary care physician and Commonwealth Fund Fellow in Minority Health at Harvard University. Dr. Sherry is passionate about expanding the conversation on primary care, mental health, and wellness in racial and ethnic minority groups outside of the exam room. She's a founder and chief operating officer of Not Just a Black Body. And through the Not Just a Black Body campaign, she has been lending her voice and platform as a physician and as someone who has directly been impacted by COVID-19 to boldly address racism in the healthcare system. Dr. Lisa Richardson, who is with me at CDC, is the director of the CDC's Division of Cancer Prevention and Control. She's been a public servant for more than 25 years. She has held numerous leadership positions within CDC and within the Division of Cancer Prevention and Control. Dr. Richardson is a highly sought expert in public health's role in cancer control and the role of healthcare delivery in cancer outcomes, health equity, and quality cancer care. And last but not least, Dr. Susan Cassandra. She serves as a chief of the Chronic Disease and Injury Section for the North Carolina Division of Public Health. And in this capacity, she oversees public health initiatives related to chronic disease, tobacco control, cancer prevention, and injury and violence prevention, and the public response, by the way, to the opioid epidemic. She also serves as the board president of the National Association of Chronic Disease Directors. Before we begin, I wanted to say just a few words about the impact that COVID-19 has had on chronic disease. So, as we at the center are thinking about chronic disease, we're not only interested in the work that we've already been doing, but we're really concerned about what the impact of this pandemic is going to be on the populations that we are particularly interested in. And we know that despite the relationship between chronic disease and COVID-19 and related disparities, the pandemic has actually resulted in a decreased use of health services for emergencies and for ongoing preventive and routine health care. Although we can't yet predict the effect of this trend on control of existing conditions, We know that about 4 in 10 Americans who were surveyed last June reported delaying or avoiding medical care during the COVID-19 pandemic for both routine and emergency care. We know that delaying or avoiding urgent or emergent care is not great for one's health, and it's been even more common among people with underlying medical conditions. And in particular, it's been more common around some of our racial and ethnic minorities, such as Black and Hispanic people and people with disabilities. The extent to which control of chronic disease might mitigate a person's COVID-19 risk is yet unknown. And we are looking into that. Hopefully we'll have some answers in the near future. But we do know that the appropriate management of chronic diseases such as hypertension, diabetes, and cancer can save lives. As we seek progress against the pandemic, there's going to likely be a backlog of critical chronic disease care that's going to have to be addressed. As we've turned our attention focusing on this pandemic, unfortunately, other things have gone by the wayside. We also don't really know the impact, for example, of potential loss of insurance, job loss, changes in other issues around socioeconomic status, changes in eating patterns that may all affect chronic disease in the long term. We know that telemedicine options may help streamline access to needed care, but let's face it, those options are dependent on digital access, and there's likely to be disparities in the availability of telemedicine across the entire country, including possible problems for elderly, for people who have lower incomes, for people who live in rural areas, for folks who don't have access to the technology, and so it goes on. The pandemic's total impact on chronic disease is still ultimately unknown. We will need to do more research into how chronic disease has been affected by such issues as I mentioned, the loss of health insurance, just stress in general, time spent at home, especially in social isolation, increasing use of alcohol and other substances. We know the opioid epidemic has not decreased during the pandemic, but actually gone the other direction, and the lack of access to healthy food. We also do not know the long-term impact of COVID-19 on people who actually get sick and who may have continued symptoms long after the 4 weeks that it usually takes to recover. So that's just a few words to get you thinking as we enter into our panel. And I'm going to start with our keynote speaker, who's Dr. Magdala Sherry. So Dr. Sherry, please take it away.
Thank you, Dr. Hacker. It's good to see you again. And I also want to extend thank you to the Association of State and Territorial Officials for having this platform, having this conversation, and allowing us to continue this dialogue. And I'm excited to share this panel with these incredible panelists. So I will share my remarks by first sharing a little bit more about my family story in the pandemic, what led me to advocacy, not just as a physician, but as a Black woman, given what we were facing, and what does it mean to move forward when we're thinking about chronic disease management, as well as how do we actually start to build trust and healing in our communities. So if I could just summarize my experience in the pandemic with one word, traumatic is exactly what I can use to describe it. March 2020 of last year, my life changed forever. I was a practicing primary care physician and assistant professor. As news is coming down about a virus coming and we're getting information on the fly together as a medical community as well as a society, I was also growing increasingly concerned about my parents, who were Haitian immigrants, don't understand public health concepts, and are calling me saying, hey, I'm hearing things on the news, what's coming, what's happening. So I'm trying to digest information as my patients are calling the office and saying, what should we do? What does this mean for us? As well as how do I take this information and translate it to my parents, translate it in another language so they understand, and also translate it to my Black community who looks at me as a surrogate for trust. And unfortunately, my father, if we all remember the weekend where major sports leagues canceled the rest of the games for the season, that's the same weekend that my father ended up going to church, and that's where we believe he contracted the coronavirus. And shortly after, he actually did not share that he had symptoms because he was afraid of going to the hospital, and didn't have health insurance, and expressed numerous times that he knows how they treat Black people in the hospital and does not feel safe. So he would not go. And eventually I would catch word around March 25th that he was not doing well. I went in there with my own PPE, checked on him at home, and my mom was relatively stable. Unfortunately, by March 29th, he got worse and I had no choice. And just to describe a scene for those joining us today, I literally had to get on my knees and beg my father to go to the hospital because I brought a pulse ox. His oxygen was in the 70s. I am watching him gasp and breathe for air. And my father had no chronic conditions, just for clarity, because I know that is the dynamic that is often discussed when we're talking about the COVID-19 pandemic in communities of color. We assume, well, it's their fault they had chronic conditions. My father had never been hospitalized. He had no chronic conditions. He was the healthiest ever in his life. And to see him struggle to breathe is an image I cannot take out of my mind ever. And I will always have that. So I eventually convinced him to go to the hospital. I go to a hospital and a safety net hospital in our surrounding community, because for me, I knew I couldn't stay. And my hope is my father would be comfortable being in an environment where he saw other people who looked like him. And there are times where I wonder if that was the best decision, but that on the fly, that is what I could make. So as I took him to the hospital, another scene I want to describe is I was able, because I was a physician and I came in with my own PPE, to stay with him in the emergency room. And he made it clear that if she doesn't get to stay, I'm leaving. And they saw that he couldn't even walk to the emergency room door. He nearly fainted from just the lack of oxygen. And to sit in there and only see Black and brown people, to hear almost every language possible and not see translators, to hear people say, we're running out of oxygen, we're running out of room, really shook me at my core. Because at the same time, in the media and on the news, we were not getting this. And at that time, it's still March, we didn't even have racial data. So we had no idea how this was really, truly impacting communities of color. So my father's there, finally able to get a bed. I remember when he was getting admitted, the emergency room doctor said, so we're going to get him a bed, but your father is number 22. And I don't know when he's going to get upstairs. I don't know when he's going to, be able to actually finally get a room. I had to leave the hospital. I left the hospital not feeling okay. I'm well aware of the racial disparities that exist and the racism that exists in healthcare. I've seen them myself as a clinician. So I did not, my ability to advocate at the bedside was stripped away from me. So when we think about our public health, precautions that we give, and we talk about isolation, understand what that isolation actually means for communities where community and being with your family member is part of your healing. It's part of our way to champion for our loved ones. And I actually had to beg the administrator to say, can I at least drop off an iPhone so I can be able to communicate, and have my father put it up so I can know what's happening, which I was able to do. My sister dropped it off, and she wasn't allowed to see him, and that's how we got updates. And just to highlight the discrepancies, getting updates even as a physician was virtually almost impossible. I had to just use other means to say, Dad, put up the phone. I just want to see what's hanging. I want to see what the monitor is saying, if I can squint hard enough to be able to see what's happening. But I had no choice to be able to leave him there, because I would get a message from my sister saying my mom was equally as sick at home. And she had a lot of chronic conditions, and she made it clear that I am not going to the hospital if you can't stay with me. And I had to talk to her primary care doctor and essentially work with her primary care doctor to take care of her at home. Ultimately, my father would die in the hospital on Easter Sunday last year, April 12th. I have to say that I don't feel like he just died of COVID-19. I believe he died of racism, that he wasn't properly monitored. They found him down on the ground. He didn't have a continuous pulse ox. So they didn't know how long he was down for. By the time he was found in that place, they tried to resuscitate him, but it was too late. And at the same time, my mother was equally sick at home. And when she heard the news, she did not want to go in, and she decided to die at home. And I'm giving the short version of the story, but there were so many times in that experience that I could not believe this is the healthcare system that existed. And even in my privilege as a physician, to not be able to have resources, to not be able to advocate for my father, to not be able to get resources at home is something that will forever stick with me as we think about how do we move forward. And in the midst of that, after losing my father, that is when I started the Not Just a Black Body campaign. It became a campaign for people in the Black community to start sharing their stories because we weren't hearing about what was happening. And it started just as an awareness campaign, just as a hashtag, as a website to tell us what's happening to your family. Let us know if you need us to help you gauge what questions to ask the healthcare providers and how we can advocate for you and how you can share the stories on social media so we can let people know that we need racial data. We need to know what's happening. And since then, it's transformed to this concept of how do we come together to re-transform and recreate a system around healing and around Black lives. And specifically to tie this into this conversation today on chronic disease, we have to look at this multifold. So when we think about what would a post-COVID healthcare system look like Dr. Hacker just explained, we have to understand that there will be people who survive this pandemic, that survive this virus, but their lives will be forever changed. Their functional capacities may change. Their cognitive capacities may change. So they're going to be having much more touch points with the healthcare system. How do we build trust? How do we address healing? How do we address racism so they can feel like they can come to us and feel heard and feel seen? The other thing to think about is mental health. We have to reimagine how we provide mental health. As a person myself, I will openly say, since my experience, I have dealt with panic attacks. I have dealt with anxiety. I have dealt with PTSD symptoms, just thinking about what I saw in the hospital, thinking about what I saw with my mother facing at home and caring for her life the last few weeks. And just wondering, it's weird for me even just going outside and seeing large groups and wondering, what is this pandemic? When is it going to end? Do people understand the gravity of this? Have people even seen what it looks like to watch someone gasp for air? And wonder, how are we addressing the mental health impact of those who have seen people die, those who have lost numerous people in their community? Because that's the next crisis that we have to get ready for if we're talking about chronic disease. Reports have said more than 40%, over 40% of people are now saying that they're having depressive and anxiety symptoms, and mental health is a big disability in our country. So we have to think about that. And the last component we have to think about, as Dr. Hacker identified for us, those who didn't go to the doctor anymore. And we have to ask ourselves why they stopped going. Yes, we asked them to shelter in place. Yes, we asked them to quarantine, but is there a component of them no longer trusting us? Is there a component of them wondering, can I trust what doctors say to me? Can I trust that they actually care about my life and care about my humanity? We have to ask ourselves these tough questions. And to really think about how we can transform our healthcare system and think about what a post-COVID healthcare system looks like means you cannot look at 2020 just thinking about COVID-19. You have to think about Breonna Taylor, Ahmaud Arbery, George Floyd, and the many others that lost their life last year. One of the things that I share is not only was I grieving my parents, I have an older brother who every time he would tell me he was stepping out of the house last year, I literally would call him every 5 minutes. Are you home? Be careful. Make sure you don't get pulled over. Make sure I know you're grieving right now, but people may confuse that as anger, especially if you're wearing a mask and they don't know who you are. Please let me know when you're home. Please let me know you're safe. Please let me know you're with your family. So it would be disappointing and disrespectful for us to be thinking about chronic disease, thinking about health disparities, and not centering racism, not only experienced in our world, but experienced directly in healthcare. So we have to think about, when we're thinking about chronic disease, how do we think about the chronic epidemic of racism that's happening in our country? And how are we going to solve that and think about justice and what that looks like? And some of the solutions that I'll end to think about moving forward is thinking about recentering healing in our healthcare system, right? It sounds ironic that that's not the center, and quite frankly, it's not our model. And when we're thinking about healing, the first thing I like to tell people is, when you think of healing, the first thing you have to think about is humanity. Are we fully seeing the humanity of the patients that come to see us? Are we fully seeing the humanity of of the people who live in these marginalized communities, in these communities that have been impacted devastatingly in this pandemic? And to think about their humanity isn't simply about just seeing them. It's not simply of just seeing them as human. It's also understanding that they live in community. And if I can't understand what they are living and experiencing in their community, if we are not standing together, united to fight for these injustices, to fight, to bring action, to fight and actually deal with political determinants of health, and actually have solutions to create a safer and a better well-being, then how are we going to actually be able to move forward? So I think we have to reimagine how we build trust. We have to reimagine healing, where we're thinking about how to bring circles so we can heal from the pandemic and what people have experienced, and reimagine how we actually bridge with our patients to center around their needs and hear what they're living with, their lived discrimination, their lived racism, and how it impacts our health. That's the only way we can move forward. Thank you.
Wow. I had to turn off my video because I didn't want to steal any of your thunder based on the way my face was looking based on your story, honestly. I really cannot say enough about how much I appreciate your sharing what must be an unbelievably painful set of events, and very powerfully. Thank you so much, Dr. Sherry.
Thank you.
Our next speaker, it's a little hard to go to the next speaker after that. Lisa, now you have to basically take it from here. But Dr. Richardson's going to talk a little bit about what we've learned to date, essentially, on the impact of the pandemic on various chronic diseases. So it's yours, Lisa.
Okay, thank you, Karen. And thank you, Dr. Cherry, for your comments. It's kind of, I feel a little like the wind was taken out of what I have to say, but I think that I would pick up, just to start, pick up where you left off on the psychological conditions and the impact of COVID-19 on that. My own son has struggled with this lack of being able to go out. He'll be a college senior next year. And when school closed and he had to come home, he did suffer depression and, had to be seen and put on medication. But, there are some people, as you said, access are not able to do that. And my brother and sister both have severe chronic conditions. And I've been, as you said, scared to death that one of them would get sick. One is in a nursing home. So these problems are real. And as you said, we have to remember where people live. They live in their communities and their humanity. Even for those of us who have not been severely affected, physically or had COVID, I don't believe any of us will be the same as we move forward into the next phase of life, because I'm still not used to being at home all the time by myself with my dog. And so there's still going to be issues of re-engaging in society and figuring out what to do next. So, even before the pandemic, Karen mentioned this, and so did Dr. Cherry, that chronic diseases are very common. Up to 70% of us have at least one. And I'm in that number. I have high blood pressure that's being treated. So the cost of chronic disease is high. And as we've moved through the acute phase of COVID-19, we are expecting a large wave of undiagnosed chronic conditions, as well as those people who've been diagnosed not being able to get the care that they need out of fear of getting COVID, out of hospitals and health systems and clinics closing to prevent the spread of COVID, which made perfect sense. And the fact that as we go forward, we are seeing more people come into the provider, but the backlog is really what I'm concerned about, is that even though the numbers of people coming in have gotten back to baseline, let's say per month, there's still a big lag of people who have not come in at all. And I was on another call yesterday thinking about cancer, what I do, how many people will end up with higher stage cancer, how many people have metastatic disease and die from their cancer, how many people didn't get treated and treatment numbers are still down. And so, as I said, there's a few examples within cardiovascular disease. There are a couple of articles in the New York Times about, what happened to all the heart attacks. Well, what people were doing, because of what, Dr. Cherry mentioned and others have mentioned, is that they were afraid to go to the emergency room because they were afraid of getting COVID. And so people were dying at home of strokes and heart attacks. and other conditions. And so what we expect, and also the collateral issues of maybe lack of physical activity, people not eating as properly. Now that as well is a two-sided coin, because some people have taken the opportunity being at home to exercise, lose weight. So I think it's a mixed bag, and it's to be seen into the future, as Karen said, about what we're going to see as we move forward. Within cancer screenings have dropped tremendously. The real issue there is if it stays low for long periods of time, we will see higher stage cancer and more people dying of cancer-related conditions. And then diabetes care. This one in particular, people are not able to get their equipment to monitor their diabetes. For all of these problems, insurance is an issue, but can't get your medicines, can't get your doctor visits, can't be monitored. And telehealth has really come to the forefront during this time, but it still really isn't, it can't replace the human touch, I think. It can replace a lot of things, but you can tell a lot of things about patients by talking to them, looking at them, seeing their body language, those types of things. And finally, the socioeconomic determinants of health and all of those things really have exposed the haves and the have-nots in our society. And it really is a challenge, with our director, Rochelle Walensky, naming racism as a public health crisis really is, I think, going to help us move forward and deal with a lot of these issues that we have all known about, but have been afraid to deal with, or we felt powerless to deal with them. And so now I think we've come to a point where it's being normalized. We have to talk about these things, and we have to deal with these things as we move forward, and do the best we can for everyone in the country that we live in. And we are more than able to do that. So I look forward to your questions at the end. So thank you. Karen?
Thanks, Lisa. All right, we have a final speaker who is Dr. Susan Casagra, and she's going to talk to us a little bit about the perspective of what's been going on during the pandemic vis-a-vis state chronic disease programs. Susan?
Thank you, Dr. Hacker, and thanks so much to the panelists and to ASTHO for having this conversation. And yeah, I think the opportunity certainly for me working in state local government, I know many of you that are in that position as well, is thinking about how do we take what we're hearing and really put that into action in what we do on a daily basis. And so that's been a place where I know I personally have been learning so much, and I know many of the colleagues around me have also been thinking about how do we really look at what is going around us and make that to build a better system going forward. And so I'll tell you some of the things that we've done. One is, I think, the learning and the appreciation that as we think about upstream and as we think about all the disparities we already heard mentioned on this call, gradually public health has gone upstream to think not only about the social determinants of health, but to think about racism and structural racism and how that impacts chronic disease and those disparities, and then really trying to make those connections, not just for us as public health leaders and officials, but also for our community partners as well. And so how they are thinking about, how they deliver services and programs, and really using that intentional lens. And that, I would say, would be the second piece, which is, learning to be very intentional, because if you're not intentional, it's so easy to let things continue on in a way that they have been. And so having the ability to take a step back to say, is this really the way we should be doing it? Is there another way we should be thinking about it? How do we incorporate all that we are learning around equity into every decision that we make? And so that has been a lesson, and I'm fortunate to be in a place where we have leaders at our department level that are actively talking about this and having that discussion on a national and state stage around COVID-19, and seeing them make very deliberate decisions. We know when it comes to things like, for example, a vaccine, like being very intentional and setting aside vaccine for historically marginalized populations. That's something that we need to do. It's too easy to not do that and think about how you deliver vaccine fastest. But really, if you want to do it right and you want to do it fairly, that takes time to think about, and you've got to really commit to doing that. And so, being in a position to really be intentional and thoughtful on those decisions, especially right now when everything is moving so fast, it's hard to make that time, but that's so important as we think about this work and how we move forward. And one of the things that, I've had the privilege to be involved in as the National Association of Chronic Disease Directors, and the organization is trying to do more around funding to states to work on activities around anti-racism and the connection to chronic disease outcomes. And we've also recently launched a challenge out to states to think about what can you be doing at the state level to really advance racial equity, and doing that in a number of ways, thinking about, again, like what training do we need internally for our own staff and for our own public health workforce, and how do we make sure that we ourselves are educated before we go out to our community partners, and really continuing to focus on that area. The second is really using our data. We know, and we're seeing this already, for example, in COVID-19, how we make sure that we have data that's informing action. You already heard so much about the statistics around the disparities in COVID-19 hospitalizations and death, but who is getting vaccine now? Can we collect race and ethnicity data? How do we know that we are distributing vaccine in a way that is fair and equitable? And what that data is showing us is that we have a lot more work to do in this area. And we're seeing that, in our state, even though we're trying really hard to be intentional about it, we know we have a lot more work to do. And so making sure that we as state partners and as part of state local government are making sure that that data is available and we're actually acting on that data, I think is so important. And part of the challenge back out to states and thinking about where they can look at that. We're also working to incorporate questions into our surveillance system, our BRFA surveillance system, which I know many of you are familiar with, that really look at the impact of race on health outcomes, and using that data then again to inform action and next steps. And so that's something we hope to have this year, the data collected. And then lastly, we are using this opportunity to use tools such as NACDD's institutional equity tool to really evaluate our own policies and programs with a health equity lens. There's a series of tools out there, from multiple organizations, not just NACDD, but really to walk you through that process and really to think about those opportunities. For example, when you have task forces, when you have stakeholder groups, how you intentionally bring in the voices of community, how you have community-led meetings and community-led decision-making, how you evaluate where your funding is going and what priorities they're going for in a way that, again, takes into account an equity lens. And really, again, taking that intentional, thoughtful process to evaluate, every aspect of decision making. And so that's also the third prong of that challenge back out to states. So, we have over 20 states participating in that. I think it's close to 25 now. I know many of the other ones are working on it, but really appreciating what these states are doing around being willing to rise to the challenge and think intentionally about the decisions they are making on a daily basis, which I hope, again, will elevate the conversation. And it's never been more clear that, as we think about health, we really need to think about the health of our communities and priority populations, because health is all linked. And so we need to really go further upstream as we think about not only the social determinants, but as we think about racism and structural racism and how we work on dismantling those root causes as we work toward better outcomes. So anyway, I'll stop there. I really appreciate the opportunity to be part of this conversation, and I'm hoping that, with continued dialogue, with continued learning from each other, we can continue to make a difference in this area.
Thanks so much, Susan. And so if the rest of our panelists could come back up on video, we'll start some questions. I think the idea here is I'm going to ask some questions, and whoever would like to start by answering it. But we have, I believe, till about 3:30 to sort of go through these. So we actually have ample time, unless they tell me differently. If we'll do the moderated questions, but it also said that we could move directly into Q&A and our moderated questions. Okay, and we'll end at 3:25. Sorry about that, just getting notifications in the comments there. All right, so I'm going to start with the first question, which could probably take the entire time. Given some of the things that we've heard today, but given what you've also, of what your understanding is of this pandemic, how do we understand the lived experiences and the processes and the lessons learned during this pandemic? And how do we ultimately translate these stories into practice or action, as I'd say, so that we can actually improve chronic disease moving forward, and particularly these gross inequities that we've been hearing about? So Anybody want to jump in?
I can start. I think we have to start by listening. I don't know if we do a really good job of that in the healthcare system. A lot of times, because we're dealing with people who have such expertise, whether it's training as a clinician or a public health official, we think we know all the answers because we know the epidemiology, the statistics, we know the gaps, and we automatically assume then we must have the solutions. I think if we really want to reimagine this, we have to just listen. We have to find a way to create listening groups, to actually just listen to the lived experience, listen to exactly what it was. Listen to the person say, yeah, I took my father 3 times and they turned him away when I thought he had COVID, and then he ultimately ended up dying, right? Like you have to actually hear it. And part of that listening is going to be very painful, because we're going to want to be quick to say, are you sure that's the reason? Was it not your fault? It has to be a unapologetic form of listening, no blaming, and just understanding. And then I think what happens with that is when you're actually genuinely listening, you'll realize that the person you're listening to starts to present some solutions to you. We'll even start to share, I wish I had this. I wish, a public health official maybe came to my church before the pandemic started. Maybe if I had heard them talking to my spiritual leader, I would have felt like I can listen to what they're saying. But a lot of that is just listening, storytelling, the power of storytelling to be able to think about solutions. And we have to ultimately believe this is a long game. There's a tendency for us to rush, right? This is how like procedures and services got really popular, because we want to put a patchwork. This is a long game endeavor. So we have to painfully agree to be in this long game together and take as long as it takes. And by starting off listening, it's going to be a nice way for us to start to build trust, because now I'll feel like I'm finally being heard.
Thank you. Anybody else want to add anything?
Yeah, I'll just add to that. It really is about listening, and I agree with you, Dr. Cherry. And the other thing is, as well, is not to be afraid to work on the problem. It really is one person at a time. Most of us get discouraged because we see this big giant thing called structural racism. Well, it is still a interpersonal, one at a time issue that we have to work our way through, and we're not going to get rid of it overnight. It's taken 402 years for us to get here. Hopefully it won't take 400 to get out of it, but it is one step at a time. And so I completely agree with that.
Dr. Casagra, do you have anything you want to add?
Yeah, I'll just add, if there's one thing that I feel like is a positive out of COVID-19 is that there has been so many different organizations that are willing to come to the table, and so many voices that are trusted by the community that we can rely on, that are willing to be partners, that we've had to rely on. And I know, many others are seeing this too in their work. And so I think that is, again, how you build those relationships and how you build that trust and how you build that, collaboration so that you can continue, whether, this is not going to be the first public health threat. There's going to be other public health threats. There's other health problems. And so how you continue to build those relationships and rely on those voices to help carry those messages.
Thank you all so much. I mean, I do want to just add to that, and it really came out for me in the earlier speakers' comments earlier today, which is that we also really have to think differently about how we do things. Because if we just keep doing them the same way we've been doing them, then we'll just keep blaming the individual with chronic disease versus sort of stepping back and saying, well, that really wasn't working then. It's not likely that it's going to work now either. And I think that's going to take a humbleness from the healthcare system, but also from the public health system, to kind of say, what did we do right? What did we not get right? And how are we going to approach this differently? And I think that's going to be a real challenge in general, because these systems, let's face it, you get involved with them and you get into them and everybody thinks they have the answers, right? So I think the next question really sort of pulls out from some of the things you guys have already talked about, which is this construct of trust and trustworthiness. And this scenario, we've seen so much of it across the spectrum in terms of how people have lost faith in science, they've lost faith in our institutions, they've lost faith in government. Again, this was something our earlier speaker talked about this morning. And how are we going to figure out ways to make sure that people start to believe that we really have their best interests at heart and that they can count on us?
I'll start that one if you. So I think trustworthiness is just like communication is a two-way street. I think with us, we should not automatically assume that because we're in the healthcare system that we're trusted sources of anything, right? So I think it really is about getting back to listening to people, listening to their concerns, and making sure that we're able to sort of understand or make an effort to understand what people's issues are and what they're afraid of. To your point, Dr. Cherry, what are they telling us? And I completely agree with your comment about patients usually can tell us the solution to the problem as well. We just have to make sure that we're paying attention, and trust is key to keeping people on track with what we want to do, what them to do to stay healthy.
Others? Dr. Sherry, you want to weigh in on this? I know you definitely have strong feelings about the trust issue, so please share with us.
I do. I have so I like definitions. So I think when people automatically go to trust, but I like to break them into mistrust, distrust, and then the trustworthiness. So the mistrust, for me, the way that I conceptually describe it is, you know, I'm kind of skeptical about you. And you have to still prove yourself to me a little bit, because I've seen some things, for lack of a better word, going a little shady. I'm not sure. So it's a little mistrust in there. But I think this idea that there isn't some trust, with mistrust, there's still some trust. It may not be full, but there's some that exist. And the reason why I think this is important is because the fact that a patient still comes to us, even though historically we have done egregious acts to their community and to their bodies, tells you there's some trust. I still am willing to be vulnerable with you, to bring my body to you for care, even though I kind of mistrust you. And then when you're thinking about the concept of distrust, I almost say distrust is like, you've actually done something to me. I distrust you. I'm not coming because I literally distrust you. I can actually finger point something you've done to me. And then the trustworthiness, when I like that word better than trust, because it talks about a complexity and a long game to building trust. And my framework of how I think about it is, it's not universal. It's incremental. It's actually not linear. A lot of times it's circular. It's going around, it's stepping out. People start to say, I didn't like my interaction with this doctor, but I think I liked my interaction with this doctor. So there's a little bit of trust, but a little bit of distrust. So the reason why I explain in this framework is because it's like an active process. It's a two-way street, just as was pointed out, but it's also a process that's always ongoing. I trust my doctor, but I have distrust at the front desk because of how they treated me. I trust the person who's actually caring for me, but then I distrust them when I can't get into my specialist care. So there's a lot of components to it. So the only way we can get to trustworthiness is now realizing that we have to start doing some truth telling, admit our shortcomings. You're right. Our EMR system doesn't do a really good job of sending referrals. Actually tell them what what the process is and what you're doing to implement that change. Realize that there's a shared power that happens in trust, right? So there's shared power and value. I want to continue to build trust with you because everything you shared to me has value to me. It's how I care for you a little bit better. And if you can share it with me, we can collaborate. And me collaborating is me showing you I'm caring. I care enough to know, although I think this is the best treatment option, I care enough about your needs to meet you where you are and make sure you leave satisfied that I've met your needs. And I think my last point is going to be, trust should never be assumed. It's a constant process that's active. That means it's always going. It's not linear. And if you keep that in mind, it's never an assumption. I will always work hard to build it in every interaction. So I'll leave it there, but I think we simplify it too much, which is why we haven't been able to tackle it. If we really understand the true complexity of it, then like we always do, we will build models. We will actually think about different ways to combat it.
Thank you. I've got a couple of follow-up questions, but I'm first going to let Dr. Cassandra say if she wants to add anything to this discussion.
Yeah, I'll just add one thing Dr. Sherry said earlier, which also I think is pointing to this question, which is listening. And I mean, you said it so well. I can't even phrase it as well as you did, but the act and opportunity of really being able to listen, and then really trying to think about how you foster, again, and you said it too, like the solutions sometimes come out of, that listening process. And so how do you foster that collaborative decision making. And I feel like our systems are also not designed to enable clinicians or state government to have the time and the ability, the opportunity to listen. And so thinking about how we create the space and the ability to do that in our interactions, I think is also really important.
So my follow-up question is, and of course, I don't know about you, Susan, I don't know the last time you saw patients. I still see patients. Lisa, I think you still see patients too, right? But I certainly through my time have seen the medical system change pretty dramatically, right? As we've moved to technology, as we've really tried to get a handle on, the checklists and, decreasing the variability and all those things. And sometimes I do worry, a lot of times I worry that in and of itself has made it much more difficult to trust. Because now you're wondering, am I trusting the person or am I trusting the machine? Am I trusting like they're talking to that electronic health record? Or are they really talking to me? Like they're not even looking at me. I don't know. I was in the, for my primary care visit, and there's a person who's taking all my initial, sometimes sensitive information, and they're literally sitting with their back to me. I mean, that makes it incredibly tough to develop a trusting relationship, right? So I don't know, do any of you guys have any thoughts about that, particularly given that everybody in this group is a physician?
I think what's interesting about that is I have thought the person who designed this exam room, did they even like do a run through of what this would look like and how you put the computer over there, but you put the exam bed over here
behind you? Right?
Yes. And it's like, who thought about this concept to actually think that this was actually going to help make it more efficient? And I think Dr. Hacker, something you just said just made me think about how we refuse to emphasize body language as a means that our patients connect with us. Right. I know when I had residents or medical students, coming through the room with me, and they'd be like, yeah, this patient was really hard to get information from. And then we go back in and I'm like, well, you were looking at your notepad or the computer the whole time. Right. Did you actually think to actually turn around and realize that they're literally bracing themselves and holding themselves like this? And how do you redesign a system that actually lets us actually take into the humanistic portions of how people present to us? It's not just you saying my chief complaint. It's also your body language. Who's with you? Did you bring family? You brought family this time. You didn't bring them last time. Do they not trust me? Do they feel like I have to explain it to someone? So I almost think we have to kind of sit down and in our minds, go through a model of what is it like to go to the doctor? What would you like to see when you go to the doctor? And then let's use technology to our advantage to help create that same environment, but make it efficient so we can actually be able to care for patients. It's almost like we forgot to, we got into this business model, tech model, and removed the human out of it.
Right. Well, it's great to hear a younger physician discuss some of that, because sometimes I feel like maybe we're just has-beens and we got to move on because, nothing's going to change. I don't know, Susan, if you wanted to add, or Lisa wanted to add anything as well.
Yeah, so to that point that you just made, it's sort of telehealth, depending on what you read or who's done the research or the look at it. Some older patients really like telemedicine because they get to talk to the doctor on the phone. Right. I mean, it's very personal. Face to face, right. And it's not even face to face. They called my house and they talked to me. So I think you're right. It really is. And they're paying attention because they're on the phone with them. And so I think it just depends on the individual. And again, it's a little bit hard to think about how do you individualize to every single patient, but it really is about getting to know the person and how they like to communicate and what sort of channels they want to do that in.
I want to bring to Dr. Richardson, because I think this may even help too. I remember seeing a patient early on in the pandemic on telehealth, and I saw their significant other in the background, but I remember from prior visits, the type of job their other significant other did. So it was interesting watching that in the background. I said, oh, is your significant other off today? And they're like, no, she just got laid off. There's so many things that happens with that, because now I'm like, ooh, this may matter as to why they may not make their visits and what that will look like. So you also get an inside look, if it's done right and you've had built trust, of social determinants of health, of all the other factors that may not like instinctively come out to your patient to say, hey, I came to see you for my blood pressure, but by the way, my wife lost their job. So you kind of actually almost get another inside world to really think about the community your patient exists in.
So I'm going to switch this up a little bit. We're getting a few comments in the chat, and I want to pull it back into public health a little bit because we can devolve totally into the healthcare system. You know, in public health, I think, well, first of all, a lot of times we don't even have technology, let's face it. But, you know, with the COVID pandemic and so many people in public health being pulled into other, you know, they had to do contact tracing, they were doing other things, they weren't necessarily doing the work that they were hired to actually do. So I feel like we've got work to do as well. And I know that there's a lot of interest right now. Our own very own center just put out a big notice of funding opportunity on this to start to think much more about how do we make community health workers sustainable and really part of the entire system. And I think for public health, we've seen them used a lot for the clinical delivery of care, as a way to sort of get out to where the patient is, for example. But now I think they're becoming more of a construct for public health. So I'm going to toss it to you, Susan, because as a state public health director, how are you seeing some of that evolve?
Yeah, I think we've had to be really creative in how we think about our workforce, especially as you mentioned, we have been growing our workforce as we have been trying to address the pandemic. And now there's even more funding coming down, which is wonderful, but us to think creatively about how we create the public health workforce of the future and what we really need. And, how do we build our systems in a way that, are nimble, are flexible, that kind of work towards some of these overarching goals. And so I think community health workers absolutely is one of those things that we have seen so critical, especially in reaching populations that are hard to reach. We've also seen that, I will say, in some of the work with the opioid epidemic, thinking about like peer support specialists and people with lived experience with substance use, being able to talk to others with, who are going through that. And you can't replace that with, others. And so thinking about how we really rely on a workforce that is from the communities that we are serving is really critical. I think our systems oftentimes don't make that easy, and how to do that and how to bring on board, oftentimes if you're hiring into government, they're looking at educational background, and we had to work with our system to say, how do you hire somebody with a past, for example, substance use history, which we think is really important to this job. And that was a different way of thinking about bringing on board somebody. So I think we've had to be creative there. I know certainly as we think about data, such, need for thinking about how we creatively collect that data and also show that data in a way that is really accessible to communities for their own, decision-making. And so we're going to have to get really thoughtful about how we build that workforce, into the future, and kind of rely on all the technology that we might imagine industry having, but also thinking about how we in public health can, use that workforce and data. So, I think those are a few of the things. I think, again, I'm so fortunate with all this opportunity now and all the funding that's coming in that we're having a chance to think about this. But I know it's certainly, a steep hill, but we're glad to be climbing it, with all of you. So thanks.
Thank you so much. I think also that, I had the benefit of being on a call with the Indian Health Service yesterday, and it was basically with community health workers. And one of the things I heard was a lot about vaccine hesitancy, vaccine confidence issues. And it wasn't just for their population that they were serving, many times it was for them. And I think that we cannot underestimate the impact that the individuals that we are talking about hiring for these positions, they are the messengers of many times. And how are we effectively listening to them, preparing them to carry that message forward? And I don't know if anybody has had that experience of late. I mean, some of that was at trying to make sure that we answer the questions as transparently as possible when they come up, that no question is a stupid question. All questions, take all comers. But how do you see these individuals who are community health workers, we'll call them, but they have a lot of different names, navigators, a lot of them. How do we as public health officials, but also as clinical folks, really work effectively with them?
So I'll start. I think it really, that those people are really trusted sources of information in the community. Because they come from the community. I'll show up and start talking, well, I'm not really from there, so why would you listen to me? Mm-hmm. And so I think it really is about having those people that grew up there, they actually live there in the neighborhood, be the messenger and also speak the language that people speak in that neighborhood. I mean, it's like neighborhood to neighborhood, right? I grew up in rural North Carolina. We talk very differently than people that grew up in Raleigh. So it's one of those where they speak the language. So I think it really is a place where it's the next instrument for moving things forward on a higher level, because there have been community health workers. They used to call them social workers back in the day, but they've been doing that forever. And so I kind of quibble with the words, but we've had these types of people and functions, since the beginning of time. So I think it's actually a great place to start.
Thank you. I'm being told we only have I don't know how much, 5 minutes or so left, I think. Probably we have time for one more question. And I did want to just pull in the whole construct of racial reckoning that's going on now. And how do we use that to also reshape our public health system, our healthcare system, so that we can do many of things that you all have talked about today?
I think we have to be comfortable saying racism. Somebody just put out an article today. I forgot, someone from IHI, and I thought it was great, about how hard it is to publish an article where there's racism in the title in our journals, how hard it is to get something out that even has word that feels it's too provocative. Language matters. So I do think we have to get to the point where our communities are seeing that we are actually being daring enough to actually open these conversations and start talking about them. And then I would just also add, it's a little, I'm trying to use the right word, but it'll be hypocritical for us to say that we're going to fight racism if we don't understand the many colleagues in our system that have dealt with racism as healthcare workers, whether they're community workers, clinicians, nurses, many people of color, including myself as a Black woman, has dealt with her own racism in the system. And patients see that, communities see that. So there also has to be a reckoning of how are we treating our own? How are we treating the ones working with us? And that actually translates when they see we're actually putting an effort to actually care for racism in our system to the people who they trust and that actually are surrogates of trust to the healthcare system. I think that'll also translate in how we address those inequities outside.
Yeah, so to speak to that as well, it's like our effort with the health equity work that we're doing in the Chronic Disease Center. It really is about making our workforce more, I don't know what the word is, but more trusting, more woke, whatever that word is, right? To sort of say, look, you guys, if we can't deal with ourselves, how are we going to deal with the public? And so really within the health, within our center, that's really been the focus of the Health Equity Task Force that I've been working with. So thank you.
Any last words, Susan, before we begin to close up?
No, I think, what Dr. Richardson and Dr. Sherry said right on. I think one of the things that, we are doing certainly at a state level, and I'm sure many of my colleagues around the country are doing, is like thinking about how do we ourselves educate ourselves so that we are better informed to be able to talk to our partners in our communities. And so that's something we are doing quite a bit of internally, discussion, conversation, trainings, having that dialogue, listening. And I think we need to continue to do more of it because this is a long road ahead.
Well, thank you. And I'm going to pull us back together now. First of all, I do want to thank a fantastic panel. Guys, we could just keep talking all day long. I want to just keep you on the Zoom call. There's so much more to be said, but I also love the perspective that people have in terms of trying to think through this. And ultimately, it leaves me feeling quite positive that we kind of know what we're going to be facing. Lisa's pointed out a lot of those things. So we're not pretending that things are going to necessarily somehow get great as soon as this pandemic is over and somehow everything's going to be solved, and that we really are taking our responsibility seriously, that we really do need to do the listening, to do the re-engineering, if that's the word we want to use, and to actually look at our own behaviors, and perhaps in a way that we have not in the past. And I think that the systems, we can talk about the systems writ large, but ultimately the systems are made up of people like us, right? I used to remember when I was working with community groups in Boston, I remember going to a meeting one time and they were all over me. And I'm like, you're treating me like I'm some government, wonk or something. You know who I am, you know me. And they're like, yeah, but you're here representing the government. And that's something that we carry with us when we go into places, and all those perspectives and feelings about government come with that as well. So we have our work cut out for us. I will say that. But as I said again, and I'll repeat, I feel optimistic talking with all of you because it really feels like people are energized and really willing to take on the hard work that we know is before us. So I want to thank all of our speakers again. And I'm not sure, Melissa, am I turning it over to you?